Go. All right. Well, good morning, everyone, and welcome to today's very special forum, an update on the Valley's response to this pandemic. My name is Bill Purcell, your devoted chamber president, and I'm joined this morning by my friend, chamber director, and the chair of the Chamber's Healthcare Council, Deborah Sammerjack. Deborah, thank you for being with us this morning. And Deb and I are really pleased to welcome a very special guest, Dr. Fred Browne, Chief Medical Officer and Vice President of Medical Affairs at the award-winning Griffin Hospital. And we look forward to your presentation, Dr. Browne. You know, I think you'll all agree, for all the Happy New Years that we've been exchanging over the last several weeks, it really has been an inauspicious start to the new year. We've seen the positivity rate, jump from the 2s and 3s to 18, 20, even 25%. Hospitals across our country have been at or near capacity. We've seen rising infections cause labor disruptions across all industries, in our schools, in our hospitals, our senior care centers. Deb, I know you can attest to that in your world and in our nonprofit world as well. And of course, we all mourn together the tremendous loss of life across our state. Nearly 9,700, 860,000 across the country, and 5.6 million across our globe. But there are many, many signs of hope as well. Just a couple of weeks ago, I joined a call with the U.S. Chamber with business leaders from across the country, and the focus was on innovation and just how far we have come in this American enterprise system. We heard from the chairman of Pfizer, who talked about the introduction of a new therapeutic that Pfizer has agreed to license royalty-free to manufacturers across the globe. We heard from the chair of UPS talking about the distribution channels across the globe. In the case of Rwanda, delivering into remote corners of Rwanda these life-saving vaccines by drone and using battery-operated cargo planes. So innovation is certainly driving our response. And then, of course, this past week's announcement from the White House, their commitment to get home-based COVID tests to every home in America through the United Postal Service. So there are positive signs as well, and we should all be very, very proud. Well, Deb is joining me from her office at Bishop Wiki Health and Rehab Center on the campus of Wesley Village. I'm here at the Chamber offices located at 10 Progress Drive in Shelton, which is just above the Griffin Vaccination Center, which has been teeming for the last couple of years. It's been, Dr. Browne, almost 2 years to the day when Griffin Health opened their mass vaccination center. It was on Martin Luther King Day in 2020, and in 10 days transformed the bottom floor of this building into a state-of-the-art and patient-centered vaccine center. And since then, Griffin has led the fight against the ravages of this pandemic, not only here in our valley, but across the state. And it's a credit to you, it's a credit to Pat Charmel, President and CEO. Whether it be through COVID testing, the operation of 2 mass vaccination centers, hosting mobile clinics at businesses, schools, and community centers across the state, Griffin has been a leader and a valued partner to the state of Connecticut in addressing this public health crisis head-on. Before I turn the program over to Deb to formally introduce Dr. Browne, let me extend a sincere thanks to all of you, all our valued members, for joining us. Your presence is an expression of your belief that the health of your family, your associates, and your employees is paramount. I also want to extend a special thanks to the members of the Valley Council of Health and Human Services who are also on the call this morning. These organizations represent the front lines of the Valley's social support system and are doing extraordinary, noble work throughout our community. Special thanks to David Morgan, the president of TEAM, who is the chair of the Valley Council. So thank you, David, and all the members. Finally, thank you to you, Deb. And I want to give you a shout out as chair of our Healthcare Council. Deb is a graduate from UConn back in the 90s, we'll say, with a BSN in nursing. She started her career at Bishop Wiki in the early 90s. In 2009, went on to earn her certification in long-term care administration from Quinnipiac University, and shortly thereafter was appointed as administrator of Bishop Wiki. She's also co-chair of the long-term care mutual aid plan for Region 2 in Connecticut, as well as her duties here as chair of our healthcare council. By day, or during her volunteer time, she's a devoted Girl Scout leader. So Deb, we're going to announce the cookie sale at the end of the meeting. So with that, Deb, thank you so much. And would you formally introduce Dr. Browne?
Sure. Thank you very much, Bill. And thanks to you, Laura, and Nancy for your continued support of our very active Healthcare Council throughout the year. The Healthcare Council is comprised of a variety of members that represent the healthcare sector. These include representatives from the senior care professionals, nurses, physician groups, local health departments, as well as Griffin Health Services, dietitians. We have been supported by TEAM and the United Way, and many, many others. The list goes on and on. We have had various topics where we have discussed things such as today that Dr. Fred is going to share with us, anything that's going on as a local health crisis or something like that, to areas of senior care that people have been interested in. OSHA has performed many seminars for us on upcoming things in the workplace and regulatory changes, as well as we continue to support several local charities for food drives, Harvest House, the Back to School program, and things like that. So it's a great healthcare council. If you want any more information, certainly you can ask any of us about it, and we would love for you to join us. It is truly an honor that I have the pleasure to formally announce Dr. Browne for his presentation this morning. As Bill stated, Dr. Browne is the Chief Medical Officer and the Vice President of Medical Affairs at Griffin Hospital. Dr. Fred, as he is affectionately called, was residency trained in internal medicine and anatomical clinical pathology at Pennsylvania State University, Hershey Medical Center. He is also fellowship trained at Yale University School of Medicine in infectious diseases, medical microbiology, and epidemiology. Dr. Browne has been awarded professional fellowships in the American College of Physicians and Society of Healthcare Epidemiology of America. And when he is not at Griffin Hospital, Dr. Browne can be found on the campus of Quinnipiac University Medical School, where he's an associate clinical professor of medicine, or at Sacred Heart University, where he teaches a course in infectious diseases in the master's program. And speaking of masters, Dr. Browne also earned a master's of business administration at the University of New Haven and a graduate certificate in population health from Thomas Jefferson University in Philadelphia. Dr. Browne, thank you for sharing your expertise and insights with us this morning. The stage is yours.
Thank you, Deborah. Thank you, Bill. It is my pleasure to present today. I'm going to pull up my slides. There's so many things to talk about, so I chose to focus a little bit more on, and give this as an update. So let me pull this up. There we are. I chose to focus. I'm going to focus a lot on the actual testing, because I think that's a really important aspect that we've been talking a lot about, and I want to make sure that people understand it and are able to really at least grasp what we're talking about when we talk about testing. We'll talk about a few other things, including the vaccines, because I think that's always important. Then I also have a few statistics. So I wanted to start off and talk about how are we making the diagnosis of COVID-19. 2 years ago it was a lot different. 2 years ago we had this unknown virus. We had no way to detect it. People were getting sick, and people were getting very sick. We had no way to treat it, and it was really very difficult to deal with. I think now it's a lot different, even though we've been seeing a big increase, and I can explain to you sort of a little bit about Omicron and sort of what we're seeing, sort of what we're seeing from a virologic standpoint. But let's talk a little bit about diagnosis, because there's a lot of confusion about diagnosis. There are essentially 4 ways to diagnose COVID-19. Sometimes you'll actually even see if when you get your test, it'll actually be CoV-2. So that's actually what it is. SARS-CoV-2 is actually the virus's name. We call it COVID-19 because COVID-19 is actually the syndrome that you get. So that's the illness is COVID-19. But SARS-CoV-2 is actually its real name, too, because there was an original SARS in early 2000, which really burned out pretty quickly. So we talk about basically 4 ways to detect this virus. The first one is the affectionate PCR. PCR, I'm going to go through each one of these in detail. So PCR. The other one is a molecular test. The third is serologic testing. And the fourth is antigen testing. Now, these are in orders of how they approached and came to us. So let me go ahead and start talking a little bit about each one, sort of the pros and cons of each one. The first one is actually PCR. PCR is an active test. So it's dynamic. It actually looks for certain areas of the genome related to the virus, and those genomes are then amplified. As they get amplified, then we can say, all right, if they are present after a threshold, then we know that they're there. This takes a period of time, and the fastest machines that we have that'll currently do PCR is about 15 minutes is the fastest. Typically, this is something that takes longer than that, but again, the fast ones can do it. So you could technically have a rapid test that is a PCR. So, and this kind of demonstrates that this is not something that's sort of just there. And as I said, the key here is it is a dynamic test. So it starts off with a sample. That sample goes into the machine. Then it actually sort of takes these targeted areas and then they grow them out. This gives us an opportunity to not only identify if it's present, but it also gives us an opportunity to determine if there's any mutations or changes within it, because little flags will come up. Now, this is not entire sequencing. Entire sequencing can only be done at larger laboratories like Jackson Laboratory, the State Laboratory. Those can actually do full-on sequencing. Now, that's not necessarily what we're talking about here. The second testing is actually molecular testing. And the reason why I'm going through this is because people get really confused about these. Molecular testing is not antigen testing. Molecular testing is a little bit different. So molecular testing is more of a static test. So it's not as dynamic as PCR. It may use proteins or it may even use genetic code, but it's static. So what happens is that you end up taking a sample. That sample is then put in a machine, and there's different ways to do this with the machine, and then that machine will actually demonstrate it. So if the early phases when we were dealing with this is actually something we saw with Abbott, the ID Now. The ID Now is actually a molecular machine. So not dynamic, but more static. It's not sequencing anything. All it's doing is looking for certain types of either proteins or genetic code. And that just says if it's present or not. And again, that's sort of the second one that we're dealing with. The third one, and I think the concept of how we need to explain this a little bit is antigen testing. And these are the tests that we're basically dealing with, the tests that you're probably familiar with, the ones that look sort of like a pregnancy test. These tests are ones that you get a sample on it. There are some antibodies that are there. Those antibodies have been specially coded to look for the antigen, and I'll explain to you sort of what an antigen is. So it detects the antigen. That antigen, if it's present, will then make it positive or negative. And this is sort of a graphic of how that goes. Sample goes in, picks up these detectors. If it binds twice, then this is actually a positive. Now, an antigen. What an antigen is, and because I'm going to talk a little bit about a serology. An antigen is actually the organism itself. It is their protein or genetic code. It's something that can actually detect it. In this case, a lot of time, it is actually the protein itself that is being detected. So that is what an antigen is. It is not us, it's not serology, it's not something that we do, it's actually something that is detected on the virus. But it is not the genetic code, all right? Or it's actually more of an active genetic code. It is actually the protein that's being produced. And I have another slide to sort of explain that. So let's go through this slide because I think this is really important. If you look at this slide, and this actually describes sort of what happens in a sequence, and I have another slide that will also demonstrate this. But what happens is you have an exposure. When you have an exposure, the natural progression of the virus, so now we're talking about the virus, the natural progression of the virus that it gets into the body, there's a period of time in which you're not infected where it is there, but you're not technically infectious at that time. You could start to get more infectious, but at the beginning, or you're not really going to have any symptoms associated with it. What happens is that then that virus starts to replicate. As the virus continues to replicate, it makes more and more in the body. As you develop more virus in your body, as you're infected, you're getting a higher, what we call viral load. As you get this increased viral load, now you are getting symptoms and you're infectious. Because you're not only are you producing this virus, but you're also expelling this virus in these droplets when you're talking, speaking, singing, whatever. That's actually what you're doing. So during that period of time, you are infectious. This period of time, as you've heard from the CDC, right now we're going to use the 5 days. It might be shorter than that, but 5 days is a safe way to say you're infectious for 5 days. Can be as long as 10 days, but 5 days is probably when you're really infectious. What happens at that time is you have a peak in your viral load. So that means there's more virus that's there. And that virus, the higher that virus is in your body, the more likely you are to spread it. So symptomatic, and you're actually producing a lot of virus. The antigen test, okay, just so we're clear, the antigen test will actually detect this period. So during the period that you're infectious, the antigen test. The other tests are a little bit different. The other tests, at least the two that I've talked about, the other tests will actually continue to detect and detect after. That's the key point. Okay, so an antigen test is usually during this period of time. If it goes past this period of time, certain tests can still remain positive. In particular, the PCR test. The molecular test, like the Abbott ID Now, that can also remain positive. And it can remain positive for an extended period of time. We do know with the PCR test, that PCR test can remain positive for up to 90 days and maybe even longer. We use 90 days as sort of anything past 90 days is when you're infectious. And that's probably why you've heard that 90 days, there's this 90-day period. It's been used in different ways, but that 90-day period is the period in which the PCR, if it's positive, if it's what we would call a false positive. It's actually not really a false positive. What it is it actually detects. So PCR detects the genetic code of the virus. Okay, it doesn't say it's infectious. It doesn't determine a viral load. All it does is it actually detects if the virus was there and if there's still remaining genetic code. Just because there's genetic code does not mean that that someone's infectious. Just means that it was there and there's some remnants. I like to think of DNA. When you think of a crime scene, there's a crime scene. My wife likes to watch those crime shows. So, there's a crime scene, and then we can actually detect DNA there. It doesn't mean the person's there, but we can detect that later. Doesn't mean something's going on. It just means that we can detect it. Same thing with this. We are detecting that RNA, and that becomes really important. So if you're getting a test and you get an antigen test, and that antigen test is positive, it can become negative, and theoretically you are not infectious when that antigen test comes back negative. However, if you get an antigen test and then you get a PCR test separately or later on, that can still be positive. That does not mean that you're still infectious. So people get really confused about that and say, well, I got a test and it's positive, so I can't go back to work. Well, which test was it? If it was the molecular test or if it was the PCR test, then it's actually the wrong test. So we just need to be really careful about that, because there's been a lot of confusion about testing and antigen testing in particular. Now, there was a fourth one that I mentioned. And the fourth one is more, instead of the virus, in the virus replicating, the virus developing a viral load and getting there, what we're going to talk about is what the body responds to. And this term is serology. So serology, when we talk about serology, we're really talking about our own immune system. And how does our immune system respond? And this also becomes really important when we talk about vaccines. What happens with our immune system is that we get a virus or an infection that comes in. That virus or infection, what will occur is we will end up getting the infection, and then we get an immediate response to that. Our body's immediate response to infections is to develop something called an IgM. It's an immunoglobulin M. And that's our first line of defense. So that what it happens is it doesn't happen super fast, but at least starts the process to fight off an infection. As that IgM moves forward, you can see during time frames, as that IgM moves forward, it actually starts to talk to the other immunoglobulins in our body. In particular, it talks to an IgG. IgG is a long-lasting immunoglobulin, so it's something that we keep in our body that continues to stay there and helps us in the longer term. But as you can imagine, the IgM is sort of that first line. You get to the IgG, which is our second line, which helps to fight off that infection, and that IgG continues to fight it off. As the illness goes away, that IgG will remain and the IgM will go away, as it's an initial fighter. The IgG stays there. We can actually detect the IgG. Now, the essential here is that once you've been infected with something, you now have memory, and you have IgG memory. This IgG memory, next time you get infection, it sort of skips the IgM phase. You get a little bit of an IgM phase, but ultimately you have this massive response to your IgGs to fight off an infection. Now, this becomes not only important when we're detecting, because we can actually do in the laboratory, we can detect to see if someone has IgGs, to see if they have antibodies. So that's what we're doing. We're looking to see if they're there. We can also see how much they have. Those terms are called neutralizing antibodies. How much do you have floating in your body? We have also determined that if they're low, if we don't have a lot of neutralizing antibodies, the likelihood that you're going to fight off an infection quickly is a lot less. If it's higher, then it's likely that you're going to be able to fight that off more quickly. And that's why it's really important for vaccinations and boosting, because what boosting does is it actually increases that IgG. And that as it increases that IgG, when there's an exposure, that means the body is already primed. The whatever army term you want to do, the sentries are all ready. They're all prepared. They're out looking for this, and they're ready to fight it off. This is essentially how vaccines work. It gets the IgM activated, the IgG, and then it gets ready to go. The problem is that the vaccine is very specific to which types of IgG it forms. It's a very specific spike protein that is produced. That spike protein develops the IgM response and then the IgG response, and then you end up having this response. If you have just a natural infection, you do have some immunity. Some people get confused and say that we have no immunity. You still have some immunity. It's just not as robust of a response if you get reinfected or re-challenged. So let me move that, since we talked a little bit about the testing, and the testing sort of touches on to the immune response. Let's talk a little bit about the 3 vaccines that we currently have, or actually the 2 vaccines and the third that's coming. So the one that we're most familiar with is the mRNA vaccine. So an mRNA vaccine, and I'm not going to spend a lot of time on this. I just think it's important to sort of touch on, because I also wanted to touch on the fact that there is going to be another vaccine that should be coming out soon, or at least another class of vaccines that should be coming out soon. For those who can't get the vaccine or want to get boosted with another vaccine or had a bad reaction to the initial vaccine, there is a third vaccine that should be coming soon. The first one is the mRNA vaccine. The mRNA vaccine, those are the Pfizer vaccine, the Mrna Vaccine. This is where you have a genetic code some RNA, some messenger RNA. Messenger RNA will actually be encoded into this little globule, this little fat globule. When that gets injected into us, that fat globule goes into our cells. It never goes into the center of our DNA. It goes into the periphery. It grabs what we call a ribosome. A ribosome is the workhorse that produces proteins in our body. It goes into this ribosome. That ribosome, now getting that code, getting that message, then starts producing spike proteins. Those spike proteins are the viral spike proteins, and those will then circulate in our body, and our body will have that immune response that I just mentioned. IgM will attack it first, IgG will be formed, and then next time we have an exposure, our body will be ready to fight it off. The second thing that we have, the second vaccine is basically the J&J vaccine. The J&J vaccine, it's a little bit different. It's actually put into, so that genetic code is actually put into a small virus that will infect us but doesn't cause an infection. It's actually usually from some other species. Viruses are very species sensitive, and they take out basically all the guts of that virus, and they can put in whatever material they want to. This is typically what we use for DNA or RNA viruses. What happens is that virus will then go in, will actually attach to one of our cells, inject that RNA, messenger RNA. That messenger RNA will get moved around a little bit, eventually make it to the ribosomes, and then when it gets to the ribosomes, it codes for the spike protein. That spike protein will then be released in the body, and we'll develop antibodies. The third one, and I kind of did these a little bit backwards, but you get the picture. The third one is actually a protein-based. So a protein-based is actually taking just the protein from the virus, and this is actually what we use for the flu right now. It's taking protein or activating the body to produce protein without using any genetic code. It is just the protein. The protein is then exposed to the body, and then you develop antibodies. It's simple. You basically take out the whole production part, and you're just giving a protein. As I said, from the standpoint of the annual flu vaccine, the annual flu vaccine is a protein vaccine. So we give the protein, then we have a response to that protein, and then we have those IgMs, these IgGs. We get exposure to the flu, we fight it off. So this is coming. That there will be a protein-based. It's just a matter of time and when they come. Given the current recommendations from the CDC, it's very likely that this will be a booster, and this could add on to an mRNA vaccine if you've had one before. All right, so that's where I am. I want to talk a little bit about Omicron. I want to talk about kind of a couple things about Omicron. Omicron is very interesting in the evolution of a virus. So Omicron is a very infectious form, of our virus, but is not that pathogenic. Now I know people are going to say, well, if it's not that pathogenic, then why are people dying? The problem is that when you have something as infectious as an organism, the more people that get infected, the more likely you're going to end up having bad outcomes just by statistics alone. So if you think about it, if everybody gets something, then when it's a 1% chance of getting a bad outcome, then you're going to see people have that 1% chance, and it just has to do with the volumes. What we've seen previously with the other viruses, with the China strain, the Italian strain, the UK strain, and then the Delta strain, what we saw is that we saw these to be very aggressive. We also didn't have necessarily until Delta, we really didn't have a vaccine either. So what we were finding is that these were infectious and deadly. What we're finding with Omicron is that more people are getting infected, but it's not as deadly. Now, there's two reasons for that. One is that it is actually not as deadly as a virus, and two is that more people are vaccinated. And I think that becomes really important about it. So that's sort of the bad news is that we've seen a lot of people who are infected. The good news is that it's a weaker virus. And the weaker virus that gets to more people, essentially what it does is it's those who actually get the virus will now get, if they've been vaccinated, or basically getting another booster. Those who have been unvaccinated now have some immunity. Again, they don't have great immunity, and we could talk more about that if you have questions about it. They don't have great immunity, but they do have immunity. This is very similar to what we've seen in the past. And now, granted, we don't have a lot to compare on pandemics. We have to go all the way back to 1918. But around 1920, to the end of the pandemic flu of 1918, the end of that flu ended very similar to what we're seeing now. There was a large increase in people who actually got infected, but there was a lower amount of people who died. So there was a high infectivity rate, but a low mortality. And this is actually, I tried to keep this as recent as possible. So this is what we're currently seeing for hospitalized patients. And that's, I think, is really important to say that this is what we're seeing. We've seen a significant increase in those who have been hospitalized. This does include those who have actually been infected and have the COVID-19 as a primary infection. This also includes people who actually have COVID-19 and then have comorbidities. So if you have comorbidities, some other illness, then this also gets included in this as long as there is an active infection in it. But we can see that we are at a peak. The question is going to be is that there's usually a lag in hospitals. So we see this increase, sort of a lag after, usually a week or two after, there's an increase in the community. So you do see a little bit of a lag in the hospitalization. But as you can see here, there's been a pretty dramatic decrease. And I can tell you, even within our hospital, we've gone from up to a high of 50% to about, we are about 30%, less than 30% at our hospital right now. So things are actually moving in the right direction, as in people are improving. One of the other things that I wanted to bring up about this, and this is actually also evolution of virology. So if you think about it, when the initial attack of COVID-19 began, it hit primarily older people. 50, 60, 70, 80, 90-year-olds were actually getting infected. Those who are older than 80, they had up to 15 to 20% mortality associated with it. Really bad. We started vaccinating, and we started to, and the virus started to mutate. What then started to happen also is that the area that became more vulnerable to the virus, the area that really wasn't getting infected and having minimal infection, were actually children. So as we continued as the adults were getting infected, as the adults were then getting vaccinated, the area in which there was an opening for the virus, people who had not had either an infection nor a vaccine, that's when we started to see an increase. And this is what naturally happen. If you're primarily focused on the olders, what'll happen is that then you start getting the younger. And that's sort of what we've been seeing in this. Also emphasizing that as we were giving the vaccine, emphasizing the fact that it is important for children to get the vaccine also. Because if they don't get vaccinated, they're sort of the dry timber, to put it, if you want to put it into terms that the fire can spread to. So again, where it makes it really important to get that vaccine. So I want to put in a couple other slides just to sort of talk about what we're seeing statewide, but also what we're seeing in the hospital. So I think this is really, really important. I've heard different things about numbers, and I've heard certain things about people who are, the actual number itself and the number that are infected. I showed you the hospital numbers because those are the hospitalized numbers. I mean, you can't really refute. Those are the people who are actually hospitalized. They're actually coming in. I will tell you from a hospital standpoint that people are getting sick, and those who are vaccinated are getting sick from COVID-19. The majority of the people who are getting sick from COVID-19, the vaccinated, are mild to moderate. They get it. Worst case scenario in that sort of setting is usually flu-like illness. For the majority is a flu-like illness. A lot of people are getting 5 days of sort of just a cold. So it turns out to be really, really good. For those who actually go into the hospital, We find that they do get sick, but we don't see patients getting very sick and dying unless they have a severe comorbidity. And again, we can go into that, but that's actually a relatively small number, or they're unvaccinated. And I will tell you that it has been very traumatic for us in the healthcare world to watch this, because we have now seen 20-year-olds, 30-year-olds, 40-year-olds, and older die from this virus unvaccinated. And that is definitely the higher percentage. And you can see on this slide, in particular, look at the lower numbers, but look at the risk of an unvaccinated person, right? So one, it's more likely, and we could talk more about this if this is a question. Again, I could talk about this for hours and days. So I'm going to try to focus on the aspect of they're fully vaccinated. So those you are more likely, if you're not fully vaccinated, to get the infection. But even more important is that you are 13.9 times more likely to die if you're unvaccinated. It went down a little bit, but this is a graph of the difference between the two. So this is age standardized weekly mortality rates. And if you look at the red are not fully vaccinated. And fully vaccinated means those who are boosted also. So if you are boosted, you do better. You definitely do better in the hospital. So fully vaccinated versus those who are not, who are not. So in red are those who are not vaccinated. And you can see last week it was 22 times more likely to die if you were unvaccinated. That's just dramatic. And again, it's dramatic for us and traumatic for us to see people die because they chose not to get the vaccine. And just to give you sort of another story, I mean, it's heartbreaking to, sit with a 50-year-old, and basically they've said to me, they say, you know what, the biggest mistake of my life was not getting this vaccine, and then they died. It's terrible. So again, I don't need to harp on that, but I just want to let you know I appeal for those who aren't vaccinated, or the friends or loved ones that aren't vaccinated, get vaccinated, because it's just traumatic. Who can get vaccinated? Hopefully this is the most updated. So right now we have the Pfizer, the Mrna, and the Johnson & Johnson. So we know who can get vaccinated. Now we need to get boosted. Boosted is important. As I mentioned before, the reason why we boost is because we can get those neutralizing antibodies up. We get those neutralizing antibodies up, we can fight this infection, and we can prevent those bad outcomes like death. And then these are, I wanted to at least throw in our numbers from yesterday. So the good news is that we have hit a peak. The numbers are going down. Daily test positivities are now down to 13%. But I think even more importantly is the hospitalizations have actually gone down. Deaths have actually gone up. Now that is not surprising to me as an epidemiologist and as a clinician. Unfortunately, the lag is going to be deaths. So all the people who have been in the hospital, and a lot of people who actually come into the hospital, if you didn't know this, a lot of people who come into the hospital are really sick. Typically the unvaccinated are not here for a couple days. They're here for 2, 3, 4 weeks. They're here. And then unfortunately at that 3 to 4 week period, there's a demise. And I will tell you that it was unfortunate. We've had stretches of 10 plus days that there's been a COVID death at the hospital, and it's, again, majority are unvaccinated. I do want to throw in that there is sort of a light at the end of this tunnel. I know this is probably a little bit more of my somewhat of my expert opinion. When we have an event like Omicron where everybody gets infected, there's, the bad thing is people are getting infected. The bad thing is that, the caregivers are getting infected as well as the patients, in the outside setting. As they get infected, that makes it even harder to staff and care for everyone. But the good news is that as people get infected, we are getting closer to herd immunity if we haven't gotten there. Herd immunity becomes really important with an aspect like this, because now we have the people who are vaccinated, we have the people who have actually are unvaccinated and survived getting the infection, that means more and more people are going to have some immunity. And at least for the next 90 days, we should be seeing less virus. And we should actually be seeing quite a bit. The likelihood to spread it is going to be really harder to do. So this could be the point where we start seeing some real improvement in COVID-19. This could technically be the beginning of the end. I'm hoping. Again, that's my opinion, is that we're really there. I mean, we get into the 90 days. 90 days is going to get us close to spring. We know that we always see a decline in the spring. We'll probably see some endemic outbreaks, so a couple spots here and there where people have not been infected. The summers are usually good. The real issue is going to be next fall when we start going indoors again. But hopefully by then we should see this more of as a seasonal or a spot infection than actually this pandemic that's there. So my hope in relation to history, into relation of what we're seeing, that this may be the beginning of the end. And that ends my presentation. I'm happy to answer any questions. So I have one of the questions is, when will kids under 5 be able to get the vaccine? I can't say that as of yet. Hopefully it will be soon. Oh, another great, there's always lots of questions. Another question is that how long after being positive can you get boosted? So that's actually a really interesting thing. And I was so happy to say, I saw on a national news the other day, I ended up seeing one of my colleagues up there and saying, and I'm like, oh boy, what are you going to say? What are you going to say? And it's always nice to hear that they're saying the same thing that I'm saying. There is no restriction in a time frame in which you get the booster. My recommendation is to get the booster after your infectious period, and so after the 10 days, then you get the booster. Now, that's actually really important. It's important to know. People do get confused, and I mentioned this a little bit earlier, is people do get confused about the 90 days. The 90 days is essentially a window in which it is extremely difficult for you to get reinfected. It does not mean that you are prepared or boosted or ready for the next infection after those 90 days. I recommend after the 10 days. The reason why I recommend after the 10 days, one is that that's the earliest you can get it. Second is that if you do it then and you're already kind of feeling crappy, you might as well get the shot, feel crappy for a couple more days, and then be done with it. And then there's actually a third one I'll kind of throw out there. People who are unvaccinated and then or people who are vaccinated and then have sort of side effects from the infection, the booster actually helps with some of those long haul syndromes and other syndromes. We've been finding that either those in the unvaccinated or those who are vaccinated who start to develop a little bit of it, boosting seems to help for some reason. I'm not sure why.
Dr. Browne, let me, if I could,
Absolutely,
interject, and I'll start with a question. And first, just a technical issue. We're using a platform today called AirMeet, which allows our guests that are currently sitting at tables to come to the stage and share some thoughts or some questions. So I'm going to put on notice a couple of people that we'd like to bring up momentarily. Carissa Caserta from the Naugatuck Health District, Kaylee Mihalko, and perhaps Tom Haynes, if he is on the call, and David Morgan as well. So I want to put you all on notice. But while we do that, Carissa, if we can get ready to bring you up, could you address the long COVID? We're reading so many examples of folks, not the least of which is Dr. David Katz, who formerly ran the Prevention Resource Center at Griffin and Yale, dealing with long COVID. Can you talk about that issue? Dr. Browne?
Yes.
Yes. Could you talk about the long COVID? Yes.
Absolutely. Yeah, no, I'm happy to. So the problem is that with the infection itself, so we know with this infection that it comes in two phases. The first phase is the virologic phase or viremic phase. So that's where you actually have the virus and you develop those symptoms. The second phase of it is called the immunologic phase. Now, again, not to confuse you sort of with the talk, but essentially what happens is our body responds to this virus. It happens with other bacteria and other microbes. Our body then responds to this, and then we end up getting stuck with these symptoms that occur later on. So it's essentially the virus is gone, but now we have sort of the repercussions related to this immunologic phase. And that's essentially what the long haul is. This happens in Lyme disease. This happens in certain types of GI infections, et cetera. Now, the way that you treat this, now what we found is that long haul, for those who are unvaccinated earlier, we found that getting vaccinated helped with the long haul syndromes. We absolutely helped with that. Boosting may also help with that. But ultimately, it's going to be a matter of time. And I'm sure my colleague, Dr. Katz, would say it's about eating right, exercising, appropriate vitamins, and good mental health. I think those are things to reduce your cortisol and be ready to fight off something like that. Those are very tricky to treat, and it just takes time, unfortunately.
Good. Thank you. I'm going to call up Nancy. I know you're there, the wizard, Nancy Gray, our vice president, who's hosting today's meeting. Could we bring Carissa Caserta up onto the stage? This past week, as we know, the White House announced the launching of covidtest.gov, trying to bring free COVID testing into homes across the country. Carissa is coming up as the assistant director at Naugatuck Valley Health District with offices in Seymour. Carissa, can you join us?
It's trying to load.
Okay.
I can talk then, you just can't see me.
We can hear your voice, Carissa. Tell us from your perspective, about we had kind of a difficult start in the new year with a statewide effort to distribute COVID test throughout the state. It was sort of catch us one can, town to town, announcing, we're open at the library from 10 to 12, first come, first serve. What is the latest from your perspective? Can you give us an update from the district?
Sure. So we haven't been a part of actually receiving those kits, but we are promoting them. As soon as we get the information, we're sharing those to our communities. What we do have is we have test kits for our long-term care, like our nursing homes that we're able to provide. But as far as the community, that's actually being held by our emergency management directors for each town. The state just felt that would be the best way to get it out to the community very quickly.
Okay, terrific. All right, thank you so much. I also want to invite Kaylee Mahalko. Kaylee, if you're out there, if we could, Nancy, bring Kaylee up. One of our other devoted chamber member is Progressive Diagnostics. Kaylee has just joined the team full time. Kaylee, could you talk about testing sites here in Shelton and the Valley and now throughout the state? Hi, Kaylee.
Good morning. Yes, thank you. Progressive Diagnostics, we have our lab based, it's in Trumbull, Connecticut. So because of that, we are able to have super fast turnarounds. Our current process is if you're tested before noon, you get results same day, and they are PCR tests, the shallow nasal PCRs. And if you're tested afternoon, then you get test results the next day. We currently have a variety of testing facilities throughout Connecticut, including one here in Shelton at 4 Corporate Drive. We have one in Bridgeport, one in Wilton, Westport, Norwalk, Wilton, and we just launched one yesterday or this week in Putnam. So we are expanding our reach in Connecticut. So wherever you go, we'll be able to assist you with your PCR testing.
Good. Thank you, Kaylee. We appreciate it. And I've taken advantage of that service myself on a few occasions. I want to turn to the announcement last week, the Supreme Court decision to prohibit OSHA from implementing the mandate for employers 100 or over. I'd say, notwithstanding that, companies across the country, and I have a headline here, from McDonald's to Goldman Sachs, here are the companies that are mandating vaccines for employees. And the list is an impressive one. It includes companies like American Express, Amtrak, Anthem, BlackRock, Citigroup, CVS Health, Delta Airlines, Facebook, and the list goes on and on and on. I had a question here, and I wonder if Tom Haynes would be willing to join us, Nancy. Tom is the president of the Haynes Group, and we had a conversation earlier this week about his policies. And Tom, if you're still with us, could you come up to the stage and be willing to share what you're doing at the Haynes Group? Are you there? Or Kathy, if Tom has left us. All right. I know you're out there. We'll give it another second. How about Bing Carbone? Bing, are you there? Bing, would you be willing to come up and talk about what's happening at Modern Plastics? Nance, can you bring Bing up? Technology. Okay, Tom, can we bring you up? Tom says he's there, but we don't see him. I just received a text. Nance, can you try to bring Tom up? Okay, while we do that, let's talk about children. Dr. Browne, in our school. There's Bing Carbone. Bing, are you with us?
Can you hear me?
Yes, we can hear you. We can't necessarily see you, but your title is up. Bing, tell us about what's happening at your company with respect to
there we go. Okay. Dr. Browne, that was a fantastic presentation, and I really appreciate it very much.
Thank you very much.
So I'm here in Shelton, Connecticut, an employee here in Shelton, Connecticut, and I guess I'm just a little bit confused at this point. I've been following CDC recommendations. So let's say I have an employee that calls me and says, Bing, I've tested positive. What we've been doing at this point is saying, okay, you're going to quarantine for 5 days. And then in order to come back, take another test. And typically it's the antigen test that we're handing out. So if an employee has the PCR test done, we've had a situation, like you said, this PCR test can go for 90 days.
Right.
So now the employee says, well, I'm still positive, which has thrown a really monkey wrench into the whole process. We are 99% vaccinated here at the company. We required indoor face mask policy back in mid-December when this Omicron really started to take hold. So I'm really, if you can address what specifically me and everyone else here as an employer, what's the proper procedure to follow when an employee says I've tested positive, and then what's the proper procedure in order to bring them back into the company?
Sure. So the CDC has actually been pretty clear on this, and they've been helpful in the past, and they've sort of made some modifications on the ways that on the duration of time. Time is actually really important. So when we talk about it, so I go by the clinical course, and again, I guess I'm a clinician, so that's sort of that's sort of what I do. It's actually the CDC recommends 5 days. So if a patient is, oh, sorry, I say patient, if an employee is actually sick, and after 5 days, they end up, they are no longer febrile, their symptoms are significantly improved, then they can return to work with a mask. They have to wear a mask for the next 5 days. They are technically, and this is where you need to be really careful. And this is where I can say you have a little bit of leg room on sort of how you want to do this. Over the next 5 days, they just need to make sure that they're wearing a tight fitting mask. So that means they can't be wearing a cloth mask. They really need to be wearing, appropriate mask that's over there. Either two papers to make sure that it's close. A KN95 would be appropriate also for 10 days. Anyone after 10 days, again, as long as their symptoms are resolving and they are afebrile, after 10 days, people can return to work. There should be no reason why after 10 days you don't keep them there. Now, if they're still sick, they shouldn't be working anyways because they're still sick.
Right.
But I would, so again, I think you can go with sort of the more liberal way, which would be to do the 5 days where the symptoms are improving, they're afebrile for 24 hours off of any type of anti-fevers, and then the 10 days. You can run it by two ways. One is that you could say, well, you tested positive, but you're asymptomatic. Then those are 5 day no-brainers. If they're symptomatic or mildly, maybe it's the 10 days.
All right. So even though we're wearing the N95 mask, and if someone tests positive, but they have no symptoms at all, and they want to come to work, we still need to keep them out for 5 days. Is that what you're saying?
That's the recommendation for the CDC. Yes.
Okay.
Yep. If they're KN95s, if they're sick, they have to stay out for 5 days. That's what we're doing in the healthcare setting. So 5 days is the minimum.
Okay. Thank you, Doc.
We're having some difficulty getting Tom on, but our HR director from Haynes is with us. Maria, thank you. It says Kevin Hale, but we know it's not Kevin. Could you chat a little bit about, and I know, Dr. Browne, you're up to visit with the team at Haynes. Maria, would you share with us what's happening, what your policy is within your company?
So good morning, everyone.
Morning.
Here at Haynes, we have a COVID policy. We require all employees to be vaccinated, at least the 2 series for Pfizer and Mrna, or the 1 series for J&J. We also require anyone who is not vaccinated. We have very few. We only have 6 people total in our company that are not vaccinated at all. They must test weekly currently. However, by the end of January, they have to have at least 1 of the series shots in order to continue employment. That is the policy right now. We also have a policy that when we hire or consider candidates for positions here at Haynes, that they are vaccinated. Currently, we are reviewing what the finalized booster portion of that will be. We would like to, based on what you just said, Dr. Browne, it makes sense to require a booster. We have to weigh that against how that's going to affect the staffing and the workflow and people's personal choices. So we're in the midst of reviewing that, and we will have a decision on that hopefully by the end of today, whether we require boosters.
Thank you so much, Marie. All right. I'm going to just look here quickly. Dr. Browne, do you see other questions in the chat room that we haven't addressed? Something about travel.
Yeah. So there's a couple questions about. I can answer a few of these questions. These are actually really common questions that I get. Next round of boosters. That's actually a really good question. So the answer is going to be is that right now it has to do with how our bodies are responding to the current boosters and developing neutralizing antibodies. There has been a cursory study that's done in Israel about a 4th booster. Right now, 4th boosters, they don't look like they're adding that much at this point. So it sounds like the 5 to 6 month period, depending on how COVID-19 is looking in the future, there may be another booster in our future. If there's sort of more uptick that's occurring, there is still a risk for morbidity and mortality, bad outcomes. It is likely, again, this would be my guess, likely that we might see something in the fall where it occurs. We may also see an annual with the flu vaccine. This is a whole different story and how and why we would do something like that. But we may see a combo in the future. The COVID-19 is a completely different virus than the flu vaccine, the flu virus. The flu virus, really, you need to do one annually. COVID, every time that you get a booster or you get infected, you develop some antibodies to it. So it's a little bit different, but we also know that if you have more neutralizing antibodies, then you're less likely to get infected and definitely less likely to have bad outcomes. So that's where I would say where we are with boosters.
So another question here: why are results of a PCR test required to travel when it shows positive so long after you are infectious?
That is the $1 million question.
Yeah.
So the answer is that I don't know, but this is actually why I chose to talk about the different types of testing, because it doesn't make any sense. Because if you've actually had the virus, and now, I mean, a lot of us have. Now that you've had the virus, then the likelihood is that a PCR is going to be positive. So you need to be really careful about that. Now, I know some airlines are requiring that you have a physician give you, sign a letter or sign off on the letter. But I think this is a matter of confusion that's out there on what certain tests do and what the importance of those findings are. So I'm sure you'll find that there's going to be some changes. And again, this has to do with the same thing about testing employees. If you're testing with a PCR, it could continue to be positive for 90 days. And if you want to be out of work for 90 days, then that could work. But otherwise, I don't know anybody who really wants to do that. But that's sort of the thing. So I just don't think regulations have caught up with sort of what's really going on with testing.
All right. Dr. Browne, it's now 9:30. And I want to thank you on behalf of the Chamber, on behalf of our Health Council, on behalf of the Valley Council, and all of our devoted members for your time, your expertise, and your insights here today. You give us a firmer understanding and a measure of hope. And we're truly, truly grateful. We're very, very grateful to have you here as a resource and to have your fine hospital leading the charge, leading the fight across our region and across our state. Ladies and gentlemen, I'm going to invite you, if you would like to stay and chat about what you heard today amongst yourselves at our tables. Dr. Browne and I and Deborah are going to sign off and perhaps join some of you if you're still there. If I can figure that out, to leave the backstage and join you at one of the tables. So thank you all so very, very much. Thank you, Dr. Browne. Have a wonderful weekend. Please stay safe, stay healthy, and we will see you soon. I will make a quick announcement too while I have you. Moving from this public health to our economy, our next major event, likely via this platform, will be our annual Economic Outlook Breakfast. It's scheduled for Friday, February the 11th. We will have, backed by popular demand, John Trainer, who's the Chief Investment Officer at People's United Bank. He's a sought-after speaker, both national media as well as on the local circuit. And Patrick Flaherty, who's the Director of Research with the Connecticut Department of Labor. Worker shortages, the Great Resignation, all of these issues are impacting all of our businesses. So we've asked Patrick Flaherty to join us to talk about the current state of the labor market here in Connecticut and what we could look forward to in the new year. So with that, Dr. Browne, I'll let you go and say thank you so much. Have a great day, folks.
Thank you, everybody.